Hey, gang, we are live. I'm in Mexico from the Riviera Maya with my mojito. And this is Dennis in the Know. This is your backstage pass to current trends, politics, and education in the dental world. It's live, it's over a cocktail, and apparently it's also under the rain right now. So, so the
Full
people that
effect.
you look, yeah, I couldn't have timed that any better. The people next to me, gang, are Dr. Chad Duplantis and Dr. Jennifer Bell. We are all dentists, we are all educators, and we are all business owners. And we are here to bring you in the know. So how's it going, gang?
I'll go ahead and we're going to do introduction to our guest a little bit differently tonight because I'm going to introduce our guest who I'm very fond of. We developed a friendship about a year ago through Dinks and then through some other connections that we had. But our guest tonight is Tom Viola. Jeff's known Tom for a long time. I've known Tom for a short period of time, but Tom is just fascinating. And I think that the majority of our guests know who Tom is by some of the comments that we've received. But Tom, I'm going to ask you, pharmacologist, is that fair?
Yeah, dental pharmacologist is what people call me. I don't even know myself. I just like to talk about drugs and talk about their effects on dentistry and vice versa. So you call me what you want. I actually get Mr. Pharmacology a lot. I'm not even sure that works, but whatever.
Well, you know what though? I guess my first question is how does one arrive to become a dental pharmacologist?
I will tell you it was a long road, but it really started with me being a pharmacist. I started 30 years ago, having graduated and really loved the profession, but didn't love my job so much and wanted to do something different. And so I went back and got my credentials to be a quote unquote pharmacologist so that really I can study drugs in practice and really understand, what clinical settings and what drugs do for live people. It's one thing to put pills in a bottle all day. No offense to my brothers and sisters who are pharmacists, and to help people and to serve them and to make sure that they get the right drugs at the right place at the right time. But it's another thing to actually see drugs in practice and see their clinical effects in real time. And that's the part that really interested me the most. And when I had to choose a specialty, the story goes, and I'll say it a bunch of times, it's when the dean of the pharmacy school said, well, pick something already. Ironically, I had a visit with a dentist that week. And the dentist said to me, dental pharmacology, I remember that course. It was Friday afternoons, 2 to 5 p.m. I was never there. And if I remember anything, I'm going to tell you no. So that's when I realized, hey, dental pharmacology might be a good specialty. And that's how it started. So
that's really interesting. I admire you greatly because there's a lot of people that I admire.
Forgive me. Sorry.
It's all right. It's time to wake up, Tom.
The whole evening seems to be going this way, Tom. So,
in college, I went to University of Texas. We had a great pharmacy school. Yep. And I started, of course, I was in biochem and organic chemistry with a lot of the pharmacy students. And I was sitting there, realizing how much further they had to go. And I was just begging to pass those classes because they were so hard. And I just know that is a grueling degree. But I have a lot of respect for pharmacists just because of their degree path. But beyond that, hospital pharmacists, oh my gosh, with what they're involved in. And then pharmacologists, like you said, how the drugs actually interact and are used within the body or within the actual clinical setting. I just am fascinated by that. I know it's a degree that I can honestly say, I know people say, don't say you can't. There's no way I could have. No way in hell I could have done it because I hated organic chemistry and I hated biochem, and I couldn't have done it. So kudos to you. So you answered my first two questions in one. Jeff, do you have any more questions pertaining to that?
Well, a couple things. One is I think, just the way that like MapQuest and Google Maps and everything has kind of made us where we don't, I think we don't pay as much attention as we used to where we're going and things like, it's like, I feel like everybody has lost their sense of direction because, oh, well, I've got Google Maps, I've got this. And I almost feel like the same kind of thing has happened in the pharmacological world because, every time, if there's if there's a contraindication or something, a little red flag pops up for us and it tells us. But I think we've stopped paying attention as much as we need to about, all of the interactions. And it's not just about that big red flag that comes up when we prescribe the wrong medication or maybe are using something incorrectly. So I guess that's my biggest question to you is, where do you see the biggest, maybe, I hate to say it this way, but the the most misunderstanding in the dental field with regard to prescribing and pharmacology? Because I really think, for most of us, that course was a long time ago. A lot of us have forgotten a lot of it. We know the big contraindications. You're going to talk about a couple of topics tonight that have changed from the time that most of us graduated. So where do you see most of the misunderstanding?
Well, you have a good point, Jeff. I mean, that fatigue that you get after a while of seeing warnings and seeing, interactions pop up all the time, makes you start becoming a little numb to it. And like you said, you sort of feel like you're on autopilot. I will tell you, in my experience now, having been in dentistry for 25 years, it's really two different roads that you have to be able to navigate successfully as a practicing dentist. You have to be able on this road to be able to say, okay, these are the medications that I'm going to use in practice today. What is their effect on systemic health? Do I know that world of, okay, antibiotics, analgesics, and local anesthetics? What effect do they have on the body? What effect do they have on that person's systemic health? Do they have contraindications that I need to be aware of because this patient has this condition, so I can't use that anesthetic agent? But on the other hand, the other road is the medications that people use to treat their systemic illnesses and what effect or impact they have on dental treatment plan. And do you have to be an expert on every medication to know what the effect is on dental treatment planning? As it turns out, if you've attended my courses, there's quite a few drugs, but there aren't that many. And if you get the general, feel of, okay, blood pressure medications do this, cholesterol medications do this, then it's easier to group drugs together, and that way it becomes a little more understandable. But it's really being able to navigate both of those roads, everything else you do in the day, that makes me respect and love you guys. I mean, with all due respect, Chad, I think it goes the other way. I much rather say I respect you and Jeff and practicing dentistry, you and JB. You guys hold the line every day. You have patients' lives in your hands, and you've got to know all this stuff that I know, plus everything else you know, and be able to make decisions in 6 to 10 minutes per appointment. That's cutting edge stuff. That'll always be cutting edge. To your point, Chad, I don't think I could do what you do.
Well, I have you on speed dial. So if I have a pharmacology question, I'll call you. And if you have a dental question, you call me, and we'll just make one hell of a team, Tom.
Sounds like a plan. I love it.
So getting into the nitty gritty, I had a couple of questions, and then there's one that popped up from one of our viewers. But and you know what? I'm going to ask that question first because our viewer that's watching, he has a very early bedtime, and I want to make sure that he gets to bed on time. But the question was, is there any concern of the interaction with NSAIDs and CBD with antibiotics?
So the hardest part for me when talking about CBD and, for that matter, cannabis are the three words that I never like to say, and they are, I don't know. No one really knows. The interactions that we can pull together from what the little we do know about cannabis and CBD are basically additive effects of the drugs we use in dentistry now. So there's nothing specific that I can say, okay, well, you shouldn't use CBD with NSAIDs like ibuprofen or CBD with analgesics, other than opioids, because we know there's a connection there. But to the drugs we use every day in dentistry, no. I can say this. There's a couple of things that stand out for sure. Number one, the use of cannabis, whether it's THC or CBD or any other cannabinoid, we know increases your resistance to local anesthetics as a patient. So you need more anesthesia than the average person would, since you're the cannabis user. But that paints you into a corner, because if you're the clinician and I'm your patient and I use cannabis, therefore I will be difficult to anesthetize. You will give me, therefore, what? more anesthesia and more epinephrine because you want it to be profound. But at the same time, then to your horror, you discover you just gave more anesthesia and more epinephrine to a patient who, by their very use of cannabis, is already hypertensive and tachycardic. That connection between cannabis use and cardiovascular effects is not very well known. The other thing that bothers me is the additive effect. So, for example, we use epinephrine in practice. That causes increased heart rate and blood pressure. Well, so does cannabis. Okay, that's a cause for concern. We use benzodiazepines in practice, Halcyon and Ativan. They cause central nervous system and respiratory depression. So does cannabis. We use opioids in practice, even though some of my colleagues will say otherwise. We do use opioids to manage severe pain. They cause respiratory depression. So does cannabis. So the point is, you got to know about cannabis because it interacts with the medications we use in dentistry, but at the same time, it has systemic effects, as I just pointed out, that impact dentistry as well. So it's that cannabis walks both sides of the street. And at the same time, there's so much I don't know about cannabis that I could write volumes about. Here are the questions I wish I could have answered, and we'll never know. Now, people say, well, we're not talking about cannabis, we're talking about CBD, Tom. Remember that. But having said that, there's really very little research on CBD as well as cannabis as a whole.
That's interesting. I think that one of the biggest problems that we have as clinicians, not just in dentistry, but in any medical profession, is that there's so few people who really are honest with their cannabis usage, whether even if it's CBD, that they're a little bit more honest with that. But as far as the actual cannabis, we don't really get a lot of honesty. So if we do have honesty, which is once in a blue moon, I think that we need to be, upfront with that patient and ask them, have they used that day, and maybe be more prudent about monitoring their blood pressure throughout the procedure rather than just that initial BP. And, we're doing that every time we're utilizing benzodiazepines and anesthetics and just making sure that we're monitoring the blood pressure the entire time. But I think it's something worthwhile for dentists to invest in is a blood pressure pulse ox, and kind of check their respirations and their alertness, especially for those patients that may have admitted to it, and you may realize you need to take those extra precautions. That's what I'm learning from this.
I agree, Chad. As you know, people don't know much about the other part of Tom Viola's life, so I do a lot of speaking and a lot of teaching, but I also serve as an expert witness in litigation. Work with the Justice Department quite a bit for substance abuse and control. And I will tell you, working in litigation with attorneys, I've learned over the course of time that vital signs are called vital signs for a reason.
Mhm.
And if we shirk our responsibilities in taking blood pressures and pulses, it's only becoming a greater and greater leverage against us, because even jurors, if a case were to go to a jury, as crazy as that may sound in some cases, the jurors are going to be asked to hear this testimony. Here's the testimony. Ready? So what was the patient's blood pressure and pulse prior to the incident, Mr. and Ms. Dentist? Well, I don't know. I didn't take their blood pressure. The minute the jury hears that, they say, how could that be? I go to my medical doctor every time, and they take my blood pressure every time I'm there. They take my weight, blood pressure, respiration. Why can't you do that in dentistry? You're a medical professional. So I've said that many times in lectures, but I'm the first one to say I understand why we don't, because how busy you are and how much you've got to get done in a short period of time. Just to hit one more point on chat on cannabis, remember that cannabis also causes immunosuppression. And again, I couldn't think of a worst case scenario in dentistry. Love you guys. I mean, I'm part of you. I can say I'm an honorary dental professional, but you work in a cesspool. You work in a fluid medium full of microbes, and if you give those microbes a foothold, they're going to grab it. So again, there's so much more I could talk about with cannabidiol, but here's some good news. Okay. If you were paying attention to your email, if it floated by, there was this study that said cannabidiol, CBD specifically, can help with gum inflammation and can help actually bury some of the pathogens that cause periodontal inflammation, but only CBD, not when it's combined with THC.
Is that like an effect of the terpenes that are in those compounds, or do we know, is that strictly a CBD thing?
So we know that right now we believe that and CBD can can shut down certain pathogens that because it has antimicrobial activity. So it has antibacterial activity. It also has antiviral activity. So it can shut down some of the viruses as well that inhabit the mouth. But the bottom line is the minute you add the THC, you've lost that. Now,
Yeah.
terpenes are a good point, Jeff, and I want to make sure, I'm glad you brought it up. Right now, if someone walks by you and they're vaping, it kind of smells like skunk. I mean, let's face it, it doesn't have a very pleasant odor.
Right.
But you all know that cannabis contains terpenes, like the same scent compounds that are in lavender and rosewood and jasmine. So it wouldn't be a big stretch for the cannabis industry to genetically engineer the plant to make more of those essential oils, so that instead of now it smells like skunk when I walk by, now when I walk by when I'm vaping, it smells like lavender. You're going to ask me, what's that? And maybe you'd want to try it yourself. So terpenes have antimicrobial activity all of their own. But I always look at it from that perspective of increasing the use because it's making it more attractive. But you're right, definitely antimicrobial activity between the terpenes and the cannabinoids themselves.
That's really cool. I know another topic that we wanted to get onto tonight was there have been some recent changes in prophylactic treatment for dental patients, and that arena has changed so much since we all graduated. I mean, it went from basically anyone with an artificial joint or a heart murmur or any kind of valve defect, pretty
Right.
much if they passed wind in the last 2 weeks, you had to give them antibiotics before dental treatment or risk infection. And it's just really, the pendulum has swung so much in the other direction. So would you tell us about that?
Yep. So I'm glad you brought it up because, there's a couple of things I want to talk about. First, just to give some reminder to the folks that are watching tonight, and thank you for being with us tonight. There is the specter of what happened in the change in guidelines for infective endocarditis prophylaxis. So it happened really back in May, but it slipped our attention, I guess maybe due to COVID or the fact that we're just so busy in practice. A lot of dentists, even during the lectures I'm giving now. And by the way, can you ask Dawn why I'm not in Mexico? I need the answer to that question. Why am I not there? I'm
You
in
know what?
freezing right now.
I will have that discussion, and you will be on the agenda. We already got Chad on the agenda next year. We'll get you on next year as well. I think
Count me in.
that sounds like a killer lineup, actually.
Love to be there. And of course, I'm tongue in cheek, but I really
I
will
know.
appreciate that. Thank you. So anyway, so it happens in May. It doesn't really hit the press. It doesn't really get into the dental rounds. But finally, we figure out, okay, all of a sudden, the American Heart Association has made a change to their guidelines and has said, we really should try to avoid using clindamycin. Well, why? Clindamycin has been used in dentistry for decades. I mean, clindamycin is one of our drugs of choice when we're treating infection, especially for patients who are allergic to penicillins. And let's face it, if I had bone infection, I don't want clindamycin in my corner for sure. But the American Heart Association says no more. They believe that the risk of using clindamycin and the risk of pseudomembranous colitis and therefore C. diff-related diarrhea outweighs its benefit in dentistry. So they want us, with the new guidelines, say use amoxicillin, and or if you don't want to use amoxicillin, if the patient has penicillin allergy, well, then you'd use something like cephalexin, azithromycin, or clarithromycin, and doxycycline. Okay, so let's run those down. So you've got amoxicillin as our drug number one, which we all can agree works probably the best for what we need it for. When the patient's allergic to penicillin, our first guess was to go with clindamycin. We've always gone that way.
Yep.
But these guidelines say cephalexin. Now, of course, you know that there's a potential
Crossover.
cross sensitivity, right? So as a little asterisk on their guidelines, they say, well, you should avoid cephalosporins in patients with a history of anaphylaxis, angioedema, or urticaria that are related to penicillin or ampicillin use. I wouldn't take that chance if I'm a general practitioner.
No.
If you even hint that someone's allergic to penicillin, I'm not going to use cephalexin because it may be 10%, it may be 8%, it may be 3%, but whatever the cross sensitivity is, I'm a little nervous about that. Okay, so then let's use azithromycin. Azithromycin is a good drug, don't get me wrong, but one of the reasons why it's second line in dentistry is because it's been linked casually to causing ventricular arrhythmias in patients who are susceptible, and can also cause drug interactions that we don't see with some of the other antibacterial agents we use. Okay, well, then what about clarithromycin? Well, sort of the same thing. Maybe not the ventricular arrhythmia, but it still has drug interactions that are of note. Okay, what's left? Doxycycline. Well, doxycycline isn't really as effective as I'd like it to be in taking out some of the microbes we see in the mouth, bacteria that are resistant to doxy. So, bottom line is, although the guidelines are out there and I welcome them and I wish we'd all adhere to them, I still think for the most part, dentists are going to use clindamycin as their secondary drug for patients who are allergic to penicillin because we really don't have another option.
Well, that
So
goes down to taking, I'm sorry, Chad, but I'm just saying that, I think that the history is so important there that, and I talk about this all the time in the lectures that I do is, that a medical history is not there just for CYA. A medical history is there for you to really look at and interpret. And
Absolutely.
we've got to be asking those questions about lower GI problems and,
That's
frequent diarrhea and things like that. It's not pleasant. Patients won't always ask, why do you need to know that? I just watched a Seinfeld the other day. It's like, they don't need to know that. What do they need to know that for? But it really becomes so critical because when I do get those patients that say, oh yeah, I have, IBS um, any of those kinds of conditions, you're always going to think twice then before you go to clindamycin.
Agreed. So if someone has a tendency for colon issues, ulcerative colitis, that kind of thing, it really wouldn't be a good idea to use clindamycin. But then again, one thing I could always say about dentistry, we have a tremendous, confidence in our arsenal of drugs. Unfortunately, our arsenal of drugs is very small. 5 anesthetic agents, 5 antibacterial agents, 5 analgesics. The number 5 comes up a lot in dentistry, but that means great drugs, but not much choice when you can't use one or the other.
Right.
I'm so glad to hear you say that, because even if I've got a patient that doesn't have an issue with amoxicillin and they've got a raging infection, clindamycin is going to take care of it
Absolutely.
9 times out of 10.
Yep.
Now, one of the things that I always mention is the chance of pseudomembranous colitis and gastrointestinal upset. And so I always recommend, and tell me if I'm wrong, but I always recommend a really good probiotic along with clindamycin. And I tell them exactly where to get it. Don't just go to Walgreens or CVS. Go to Sprouts, which is a kind of a holistic grocery store, or there's a place called the Sunflower Shop. And I said, get one that's refrigerated and that's, a really good probiotic. And the people that work in the department there are nutritionists for the most part, and they're pretty knowledgeable as to, you say probiotic, they're gonna be like, right here, you want this one. And you'd be amazed when you read those bottles as to the billions of active bacteria in there. Wow, so
I think you said that better than Carl Sagan, Chad. That was pretty good.
Yeah.
Billions.
Yeah, well, holy crap. Somebody asked me, I've taken probiotics for years just because my wife's a big believer in them. And to be honest with you, a lot of times I take what she tells me to take. And I looked at the bottle, I was like, holy crap, that's a lot of stuff in here. How can they fit that into this pill? How can they fit that into this? But, we order our probiotics from a specialty pharmacy. And so I think it's really important to understand that as well. But switching gears, I have been resistant to change the antibiotic recommendations as well. I'll just go ahead and say that. Fortunately, we're finding also that fewer and fewer patients are recommended for antibiotic prophylaxis, but it's needed. Switching gears, I want to ask you about anesthetic, because antibiotics came up a couple weeks ago. We were going to get to that regardless. Clindamycin, I wanted to hit on. You got there before I got there because there are so many people that have stopped prescribing it. But anesthetics, really interesting. We've heard all these differing reports on not to block with septicane.
Yes.
And, the hardest, I don't care if anybody agrees with me or not, the hardest freaking tooth to numb in a patient's mouth is number 18 on a male that's large and could kick anybody's ass in this room. That ain't getting numb. And so I just threw it out there a couple weeks ago. I said, hey, what do you all do in these instances? Because I've had a tried and true injection technique for years where I go ahead and I block with Sit Nest. I let it sit in there for a minute or two, and then I go back and I block with lidocaine. If I need more, I infiltrate with Septicane, and sometimes I just don't get it. But David Rice came back and gave me his technique, which worked like a charm because I could never get this guy numb. This guy was he was numb till the next Tuesday after I worked on him with David Rice's technique. But so many people chimed in and said, I block with Septicane all the time. You know, it's not an issue. And I know that sometimes we chase after the 1 in a millions. Yes. And I know it's definitely a larger number than that, but sometimes we chase after the littlest of things just based on an adverse reaction.
Yep.
So should we truly be that fearful of that, Tom, or what are your thoughts on that? And then I heard seat nest can cause the same thing as Articaine.
Well,
and I've never had an issue with seat nest.
But the powers vested in me by the AGD and the ADA, I cannot say that you're allowed to use Septicane in mandibular, Articaine in mandibular blocks or Probiotics in mandibular blocks, because there is that information out there that says that 4% anesthetic agents delivered in mandibular blocks increase the risk of paresthesia. But every time I deliver a course on anesthetics, Chad and Jeff, I'll tell you, I ask for a show of hands. How many of you use Articaine in injectables when it comes to mandibular blocks? And a lot of people raise their hand, and I've asked them, what's the incidence of paresthesia? And they say never had a case or very few cases. So I think there's a lot to be said that I look at it this way. In dentistry, we have to remember that when we chase anesthetic effect with volume, we're always going to lose, because every cartridge of anesthetic contains acid. And the more anesthetic you add to the tissue, the more acid you're adding to the tissue, which drives down the pH of the tissue, which increases the difficulty in maintaining good anesthesia. So if you're going to increase the anesthetic effect, the best way to do it is with higher concentration, not volume. Well, that lends itself to believe that, okay, I need a 4% anesthetic agent, one of the strongest we have. I like Prilocaine. I like Articaine. I agree with you, Chad. I think Prilocaine is probably a better choice for infiltration and for some blocks because it seems to penetrate really well. But you can't argue the fact that Articaine has incredible fat solubility and can penetrate tissues deeply to the point where deeper than most anesthetic agents can. Now, here's the dilemma. Articaine does such a good job in penetrating tissue that if you're not 100% spot on with the injection, that may work against you, where the Articaine may spread away from the site of action where you want it to be. So accuracy and technique are important. And I would say that I think if you ask me what are the major causes of paresthesia, I'd tell you it's the procedure itself, third molar extractions especially, and needle trauma. Okay, well, both of those, I don't care what's in the cartridge, it would have happened anyway. So yeah, can you use Articaine? Of course, my answer has to be no. But do I know plenty of people use Articaine and use it successfully? Do I know plenty of people use Prilocaine and use it successfully? Yes, but again, the theory is 4% anesthetics like Articaine and Prilocaine increase your risk of paresthesia and mandibular blocks.
I love what you said. Don't chase it with volume. I think that's really important. And I think that, I'm very interested. I was very interested last week to find out that so many people block with Septicane, because it's honestly something that I've never done. It's usually an infiltration technique, which is what David Rice's was. But it's gonna, chasing that needle in a haystack, or trying to avoid that needle in a haystack, I guess.
I always talk about risk versus reward, and I don't know, Chad. I have injected with Septicane for my blocks. I mean, I've always seen it as the opposite. So a lot of times we'll infiltrate with like lidocaine, just basic lidocaine, because it works so well in infiltration circumstances. If I need deeper anesthesia, if it's an endo or something, yeah, I'll use Septicane. But I have always used Septicane, or for as long as it's been around. We still have never, I'll knock on whatever this is, it may not be wood, but we've never had a paresthesia case. But I think the issue goes back to, the problem that we have in dentistry more often than not is insufficient anesthesia, as you said, for those lower first and second molars, or God forbid you're working on a third molar. And I really do think, and this is opinion, but I really think that most of what we see with paresthesia is more trauma related than it is the anesthetics that we're using, because, well, I don't remove third molars. I'm not doing anything as invasive, and I think that's why I probably haven't seen it. Now you ask the oral surgeons and they'll say, yeah, I had it. Well, was it the third molar extraction, or was it the anesthesia? But I just want to keep my patients happy and comfortable. And and with that kind of a track record, I just don't see a reason. I don't think there's enough evidence to prove that it's even the orticane.
And keep in mind, this 4% in paresthesia thing sort of takes us away from really loving some of the other features about articaine and prilocaine. For example, the reason we love articaine is because it's an amide, right? That's broken down in the bloodstream. So it'd be an ideal candidate for someone who has liver disease. Okay, that's overshadowed a lot by the fact that of the 4% paresthesia thing. And prilocaine has every advantage of every other anesthetic agent all lumped together. It's available plain. It's available with the 1 to 200,000 dilution epinephrine, which many people believe is better than the 1 to 100,000. It's the easiest to metabolize. Yet we worry about using prilocaine because of the potential for paresthesia. So I don't want that to stand in our way, because at the end of the day, I think you can both agree with me that our job is to give our patients pain-free dentistry, and we've got to do whatever we can to get there.
So as I read this, the paresthesia is basically linked to the percentage of the anesthetic in the solution.
4%.
But that's the thought process.
Right.
Okay.
And that's why I often tell clinicians who say to me, I don't want to risk paresthesia, not in this patient. Okay, well, you don't want to be wimpy 2% lidocaine. You don't want to be big, bad 4% articaine or prilocaine. Who's Goldilocks here? It's 3% mepivacaine. I can't use that for a block, but that's where I think, because there's no epi, it doesn't last very long. Remember that you could always double up. You can always use mepivacaine first and then lidocaine with epinephrine after to sort of seal the deal.
It's funny you say that, because years ago, I don't know if I know you went through this, Jeff, but remember when there was the shortage of the lidocaine and the mepivacaine, and I mean, crap, our choices were limited. We're batting 3, and you better hope that they work. So I totally get it, and I think that the thing that I'm always concerned more so about on an injection is, and you can ask any of my team members, it only takes once or twice. I'm more so concerned about injecting into a vessel rather than, I aspirate 20 times as I'm giving a real slow injection, because I mean, you can start that injection and you're going, and you aspirate again, and all of a sudden, man, you get this big puff of blood. You're like, oh, reposition. I'm more so concerned about that, because when you light somebody up like a Christmas tree, they will never, ever forget it.
That is the truth.
That's my roommate in dental school. He went in for allergic reaction. We used to play this golf course in San Antonio called Pecan Oak Plantation or something like that, and it was known for all the pecan trees. Well, he didn't know that he was allergic to pecan trees. So about the 5th time we played there, he ended up in the emergency room that night. And he tells this story so well. The nurse or the doctor told the nurse to give the patient, he's sitting there and he can hear everything, and she said to give him, X milligrams of epi sub Q. She gave him X milligrams of epi IV.
Oof.
And he said that as soon as she gave it to him, he just sat straight up and was like convulsing, and he could hear and see everything. And he said the nurse's eyes got this big. Of course, it's at a teaching institution. It was a student. She was crapping her pants. He probably crapped his, but I mean, it's just that's always, I always think of that, when you do it. But
that's my biggest complaint against mepivacaine. People say, well, I'll use mepivacaine because I don't want to use any epi. But by the time you inject the mepivacaine, it wears off in about 40 minutes. You're not done with the procedure, so you have to get them again with another round of injections. And before you know it, the wearing off, the pain from out of left field means what? A surge of endogenous epinephrine. Then you come out with the needle. That's another surge of endogenous epinephrine. And now they're just waiting for the second set of injections to wear off, because the first that wore off, so that's even more endogenous epinephrine. You can make the argument that a patient receives more epinephrine when you use mepivacaine, or the contrary is they would get less epi if you just use epi.
Well, and
Yep.
you always have to consider, overdosage as well when you don't have epinephrine in there and you're going in and I think it's really easy to make that mistake, and I've seen people do that.
Yeah.
So, we have to be really aware of maximum dosage on our anesthetics, especially in younger people.
Yeah, and I mean,
Pediatrics.
I've called
Very. Yep.
procedures based upon maximum dosages. We had X amount planned, and you're like, "Hey, sorry, I'm not going to create some sort of toxicity by continually injecting you with this anesthetic. We've got to stop. You've reached your limit, or we're pretty damn close to it." And
Yeah.
so that's a
Well,
great
and
point, Jeff.
yeah, the higher the percentage too. So but
Yeah,
it's 3% without epi is the one that scares me the most. 4%, because typically we don't have to use as much when we use an articaine solution with epi
yeah,
or something. But when you start overdosing patients, because you're not using epi, aside from the endogenous epi, I think you always have that risk there, and you really need to be aware. And not even just smaller or younger patients. I think you really have to be aware of that in elderly patients and also in smaller adults.
Think about
yeah,
this. You should know that the two patients you'd probably be most worrisome in using epinephrine, geriatrics and pediatrics, are the ones that really can't break down anesthetic agents very well. And mepivacaine is one of the most difficult to break down anesthetic agents. So you create a perfect storm. You give the one patient who can't break down
Mm,
anesthetic agents very well the most difficult to break down anesthetic agent, and you give it to them in high doses because you're constantly redosing. So I get that. It makes you kind of worried to even use mepivacaine in the first place.
yeah, I'm not a big fan. And even
no,
it's what you said. Even the patients who say, "Well, I had heart palpitations when I had epinephrine before." I go, I mean, and it happens sometimes. We all catch a vessel every now and then, even if we aspirate 20 times and
yeah,
do whatever we can. It just happens sometimes. But I'll also explain to them, you're going to make a lot of epinephrine, and I don't want to overdose you. I want you to be comfortable, and you're going to make your own epinephrine
yep.
if you're not comfortable through the procedure. So, I think it's just something that I always try to shy away from is the use of mepivacaine, unless it's just really a short procedure in a limited area.
Excellent.
Well, I know that we got to what I wanted to get to. I know there were some things that we had hoped to get to, and I want to keep everybody's time interest in mind. Tom, I would hope that you would come on again in a few months. I really would. And I know there were a couple things that you wanted to get to. And if there's anything that you would like to post, please, we would love for you to contribute to our site. I mean, there's a lot of people out there that really respect what you do. There was one person that said you were funny. And I was like, Tom's not funny.
I
You
keep
know?
telling my mom to stay off these message boards, but she
Yeah.
maybe because I pay her. No, I'm just
I,
kidding.
I love your dry sense of humor. That actually
Yeah.
is. I find it funny too. So.
No, I appreciate that. And,
Thank you.
with that being said, Jeff, should we close out and then just, I think I'm going to grab Tom by the tail and pick a date, maybe in April or May, that he can come
I
back on
I
again.
think
And
I think we got to have a quarterly pharmacology thing.
yeah,
I think we got to have a quarterly pharmacology.
yeah,
And this is just too good. I mean, I learn something every time we do this. So,
yeah,
um,
absolutely.
I
yeah,
learned
if
from you guys. You, JB. I mean, you guys are at the forefront of this industry right now. Thank you so much for doing what you do every day. I learned from you, and I know a lot of people in this audience can say the same. So thank
well,
you
I
guys.
appreciate that. And you
thank you.
said
Right
something
back at
earlier.
you.
You said you're like an honorary dental professional. I'm not sure what the hell you think honorary is. You're a dental professional, Tom. Come on. I
Yeah,
mean, let's be real. You know
yeah,
more than half of us, maybe 99% of us, actually, as far as what you do. So thank you. Thank you for keeping us straight with the drugs, man.
absolutely.
Have
All
it back
right.
Yeah.
anytime. I
Great
look
to
forward
see you,
to it.
Tom, as
Thank you.
always.
Thank you. Thank you.
Yeah.
All right.
I'll see
Have
you
a
in
good.
Thanks,
Mexico.
Tom.
Yes, I'm pretty
Yes,
sure.
next year I'm hooking this up.
All right. Thanks, Tom.
Thanks,
All
everyone.
right.
Thanks,
Take
guys.
care, Tom.
Jeffro, close us out, man, and then go get
Uh,
back to your party.
Absolutely. Well, first of all, sorry about the internet. I knew I was doomed when I started bragging about being in Mexico and showing you the beautiful pool behind me and drinking my mojito. I was like, oh, here it goes. The rain came down, the internet went out. It was just, that was a ton of fun. But anyway, from my hotel room in the Riviera Maya, thanks for watching Dennis in the Know. It's always great to have all of you here. If you all get the chance, I would tell you to look for this event. This is an incredible event that Midway Education puts on. And so thanks to Steve Kizzy and Don Metcalf and Ryan Cleary and the Kelsey Banfield and the whole gang over at Midway Dental. Thanks to our great guests like Tom Viola. Thanks to all of you for inviting your friends to join us. We had another great week. Of new members, and really just very proud of that, and really appreciate the trust that you guys are all putting in us. So Chad, cheers to you, my friend.
Cheers.
I'll be seeing you next weekend, I believe.
Yes, sir. Looking forward to it. Check your email.
Yeah, I certainly will. I certainly will. All right, gang. So have a good night, and we will see you next Wednesday.
Good night, everybody.